Calling over the retina session, waiting eagerly, all the retinologists. We have our secretary, sir, Dr. Devashish Das. The moderators for the retina session, please come forward.
Thank you, Dr. Swati. On behalf of Ophthaeva, I welcome you all to this retina session. After extensive discussions on glaucoma, refractive surgery, and eloquent talk of Dr. Vishali about cataract surgeries, now we move on to the more core subject, that is retina. May I invite our chairpersons, Dr. Devashish Das and Dr. Professor Pradut Naran Bishas, to be on the front seat, please.
I would also like to invite Dr. Somen Mondal and Dr. Jonaki to please come on the first seats. They'll be the panelists for the session.
May I now invite our speakers. So our first lecture will be by Dr. Debaroti Mukherjee. She is going to present an interesting case. To all the speakers, please stick to your time to 3 minutes. And our next speaker will be Dr. Sneha Jain. Please, Sneha, please be ready with your presentation. Thank you. So now over to Dr. Debaroti.
Good afternoon, everyone. Since time is short, I am getting straight to my case. 70-year-old lady presented with pain, redness, photophobia in the left eye, gradually progressing over 1 month, and she already had cataract, but her vision further declined after this. She had no history of flashes or floaters, and she had consulted an ophthalmologist 3 weeks back, but nothing significant was recorded, and she was using some CMC drops. She is a known diabetic, but she does not have any history of joint pain, TB, autoimmune disease, major surgery, hospitalization, vaccination. She gave a vague history of some facial rash 8 weeks back. And when I asked for the prescription, nothing was mentioned, and she was on some steroid antibiotic cream and antihistaminics. There was no abnormal facies. There were few scars on the inner canthus, mild redness, lid swelling, tenderness on the left side was quite marked, and the BCVA was 618 and 624, and no improvement with pinhole. The pupil, right side was okay, but left side was distorted and sluggish. Right side revealed a cataractous lens and nothing much, but left side there was ciliary congestion and fine dusting, and there were 2 or 3 small non-granulomatous KPs and irregular anterior chamber with 2+ cells and 2+ flare. There was a pinpoint synechiae in the superinasal quadrant, no nodules, no transillumination or NVI, and pigment dusting on the cataractous lens with over the anterior capsule. The IOP was although high. It was 28. So this, I don't know whether it's visible, they are very small, fine KPs. So posterior segment on the right side was normal, but left side did not dilate well, and because of the synechiae and cataract. But I could not make out any gross areas of vasculitis, retinochoroiditis. Macula and disc seemed okay. I advised for PP, hemogram, OCT, and USG just to rule out any other posterior segment involvement, and started her on these following drugs. I started benzamide because her IOP was high. OCT, there was nothing significant, and B scan also no vitreous membranes, echos, or any mass lesion. And follow-up, it had resolved, the cells flare had resolved, synechiae had released, IOP was high, so I added another brimonidine, tapered the steroids, and referred to a physician. So is this just another case of anterior uveitis we see in our daily practice? What are the things that do not fit? First is the age group. The age group is quite high, so it is not a usual age for uveitis. And prolonged course, tenderness, KPs, high IOP, and scars do not match a normal case of idiopathic anterior uveitis. So I asked her for some pictures of the rashes that had occurred. And here you can see maculopapular rashes along the distribution of the facial first branch of the trigeminal nerve, and the root of the nose is also involved. Unfortunately, this was missed by the medicine consultant as well as the opthal consultant, because most of the rashes had healed, as it is quite few, only 2-3 crops. So this is my diagnosis, varicella uveitis with previous history of herpes zoster ophthalmicus. Now prevalence is quite high. 70% of patients with HZO have uveitis, but it is often missed because it usually starts late, that is 4 to 8 weeks after the rash, and by that time the rashes may have healed. It's mostly unilateral. Sometimes in immunocompromised patients or with posterior involvement, it may be bilateral. Hutchinson sign, as we know, is a predictor, but even if Hutchinson sign is not positive, it can be present. So sectoral iris atrophy is a telltale sign, but I did not find any case up till now having this feature. And KPs. KPs, if present, then we should always keep 1DD as viral, that is herpes group of virus in our diagnosis. So we all know that the incidence of HZO has increased following COVID, and I myself have seen 5 cases of HZO in the last 5 years. And therefore, we should be aware of the complications related to the eye and the risk factors where we need to diagnose and send for further checkup, like if we suspect a systemic malignancy, radiation, HIV, major surgery or trauma. Now, spectrum of ocular morbidity, we are all aware of the corneal diseases, but we should not miss the following also. That is, uveitis is the second most common ocular morbidity which occurs in HZO, post-herpetic neuralgia, scleritis, ocular motor nerve palsies like third nerve palsy, increased IOP, which I had in my case, which was one of the causes I suspected this, because the herpes group of virus causes trabeculitis and features like Poshner-Schlossman syndrome. And the IOP can be high, and it can remain high and cause glaucoma if not detected and treated. It can also cause ARN, optic neuritis, ptosis, cicatricial complication. This is another case which came to my OPD, and this gentleman had herpes zoster ophthalmicus along with complete third nerve palsy, ptosis, and he was later investigated and found to have a disseminated malignancy arising from the adrenal gland. I don't know the exact diagnosis, sorry. So take-home message is antiviral drug. When you are examining a patient with HZO, always inquire that whether he has received the antiviral therapy or not, because if he has not and 2 weeks have not passed, you should definitely start acyclovir, because it reduces the chance of infection. You are also at risk of acquiring the infection, and it also reduces the incidence and severity of the ocular complication as well as the duration of post-herpetic neuralgia and the severity. It does not reduce the incidence, but it definitely reduces the amount of morbidity. This is the recommended antiviral therapy for these cases. And another thing is the role of, I would like to stress the role of vaccine. Nowadays, chickenpox vaccine is available. Many of us who have not been exposed, like myself, I have not got chickenpox in my lifetime till now. But after I saw that patient, that gentleman, first thing I did was I took a chickenpox vaccine because I was at risk of acquiring it, and I got the shot the same evening. And the second is, now many people are having low immunity, so please ask elderly patients over 50 years to take a booster dose. And now children are receiving it routinely at 1 year of age. If they have missed, or if you see any patient who is immunocompromised, do advise them the vaccine. It decreases the disease burden as well as the neuralgia. So follow up, what I missed was I did not examine the cornea for hypoesthesia, so I made sure next time when she came I checked for the hypoesthesia, and I will be very cautious to check her IOP. Cataract was there, did a cataract surgery, she regained good vision. Thank you.
Thank you, Debaruti. Now the panelists, Dr. Jonaki, your take over this.
I think a very good presentation that we...
Thank you, ma'am.
Yeah, and will help us in our clinics also. And you should see the response on follow-up, how it works. And another thing, it's not indicated on all patients, but we can do one, just in case it doesn't respond and all, we can go for an AC tap also for the PCR thing. Else if it responds, then it's fine.
Ma'am, actually, I thought of it, but within 2 weeks, most of the inflammation had come down, but IOP was high. So I thought if IOP remains high, I will still do, but the clinical pictures actually were
it responds
sufficient, so I did not further. But if it would not be available, I would have definitely advised for it.
Thank you.
Thank you.
Yeah, first of all, excellent case. I mean, it's a very good representative case for juniors who are present here. The one telltale thing that she had mentioned in this presentation was the high IOP. So whenever we have a uveitis, an anterior uveitis with a high IOP, we should always think of viral disease, viral infection, and then you go back to the slit lamp. When you have a high IOP, you go back to the slit lamp, see if you can get any patchy iris atrophy or a sectoral iris atrophy. Sometimes, like in her case, there was no atrophy there, but a high IOP with a uveitis should always trigger that button, number one. Number two is, if I had been in your case, I would have gone for an AC tap followed by PCR for VZV as well as HSV1, 2 and CNV. Because we know that in Boschner-Salzman, these are the most common causative organisms.
Yes.
So that's it. Otherwise, very well managed.
Thank you.
Good.
Due to paucity of time, I will request the next speaker to be there, Dr. Sneha Jain.
After a wonderful talk by Dr. Debarati, I don't know what I'm doing here. This is basically a PCV case which has been treated by pneumatic displacement, and I've already shown it 2 days back. So just for the fun element, so this is Bubbles to the rescue. So I'll be sharing 2 cases through a small cartoon. And this is a story of a beautiful retina of Townsville, which is being attacked. Can I get the volume, please? The beautiful retina of Townsville.
Soon you will be upon Townsville,
As being attacked by the
where I will banish
PCV.
their souls to the eternal darkness of the storm.
But wait a second, we have our heroes, the anti-VGF girls, to combat the PCV. But what happens when the PCV creates a large submacular bleed? Will the anti-VGF girls be enough for this monster? Here comes the entry of our hero, the C3F8 bubble. Delicate but effective. It displaces the bleed and helps the anti-VGF girls win the battle against PCV.
Bubbles! Great job!
Yeah, so with this, we come to our 2 cases. The case number 1 of a 75-year-old gentleman, diabetic and hypertensive, who came with a counting fingers close to face with a large submacular hemorrhage. And the OCT showed subretinal blood, a multilobe PED with polyps and pachyvessels. So went ahead with our anti-VEGF and our C3F8 bubble to displace the macular blood. This is a procedure that I followed. It will raise eyebrows, I know, because I'm introducing the vitrectomy cutter for doing a pneumatic displacement. But this is how I've done it. Making the globe a bit hypotonous, injecting the anti-VEGF slowly through the same port. Removing the port. And then the usual protocols of a C3F8 gas installation, that is, we tell the patient to look so that the point of insertion is at the highest point. The needle is through the pars plana we enter, make it vertical. Only a small part of the needle being in the vitreous cavity. A very slow injection of the expansile volume is done so that to get a good bubble, single bubble. Once that is done, we check the IOP and put the patient in prone position. So this is the magic of the bubble. So at presentation, then 1 month and 2 months, you can see how beautifully the blood has been displaced. Also, the OCT pictures show a very different picture. This is at presentation. You can see the submacular blood, the tall peak PEDs with the polyps. And this is just after the first dose of injection and the pneumatic displacement, where you can see the flattened PED, a very well displaced submacular blood. This is again, so the patient did well, and I did inject a second dose of brolucizumab to further flatten the PED, and this is the patient after the second dose. So from a vision of counting fingers close to face to 636 N18. This is again a second case of an 82-year hypertensive patient. Same picture for PED, blood, SRF, everything else. And again, the same combination of C3F8 gas and injection brolucizumab. So you can see how beautifully the blood has been displayed. This is the one at presentation, lot of blood, very tall peak PEDs, and this is just a month after the procedure. I have injected this patient again with brolucizumab. Let's see how it comes. So from 5/60 to 618 parts N8. Thank you.
Oh, very nice presentation,
Thank you.
Dr. Sneha. Very entertaining also. Any comments from the panel?
Sir.
Nice presentation. Set? Yeah. Yeah, we had actually, yeah, that was a different forum where we had discussed this. So, but again, not everybody here were present there. So, yeah, two things. One is the C3F8. Yes, if you have central subretinal blood in the macula, then C3F8 definitely helps. And brolucizumab, of course, is taking care. And just one question: how many times did you repeat the brolucizumab after, like, in the post-op period?
So these patients have been there. The first one was, it's a 6 months follow-up till now. It's only 2 brolucizumab, and the patient is maintaining 636 N18. So that is the one. And the second one, he's just a 1 month follow-up. I have injected the second dose, and he'll be coming up later.
Fantastic.
Yeah. For brolucizumab, I normally do after 2 months. I don't inject monthly. I see, and I have to, basically the action does continue up to 2 months. After 2 months also, if there is fluid, then only I go in to inject. Or I feel, I do an OCT angio also, which I have not shown here. If I feel that the activity is still there, then only I inject.
Excellent video.
Just an addition, in such cases, we also add TPA, that tissue plasminogen activators.
Yes, ma'am.
Just to enhance the, removal.
Clot lysis.
Yes.
Clot lysis, yeah.
So the
but
thing
here
is,
it's responding well, I
yes,
feel. So.
well. And also the cost factor, the
Yes,
setting
that's one
where I work, the patients there, they are not that economically
I
well.
understand, yes.
Yeah, so the cost factor does come into play.
One thing for retina enthusiasts and people who want to do retina or are right now doing retina fellowship, just to add, what she had showed here is she is doing a partial vitrectomy, but same thing can be done even without a vitrectomy. If you do a good paracentesis and a mannitol before and maybe a diamox after, so even without vitrectomy you can do the same procedure. That's it.
Even, I would like to add this, even after all this, I do add a diamox, which I give the patients 2 to 3 hours after the procedure. That is the time when the expansion starts. So that is the time when I tell, not immediately after the surgery, but 2 to 3 hours after, they have to take a diamox.
Thank you, everyone. I now... Oh.
Yes, please.
When you combine this procedure, anti-VEGF with gas, how you instruct the patient for the positioning?
Okay, so I was not aware. I came to know just 2 days back that you can put the patient in supine position for an hour so that the injection works better, and then you put the patient on prone position so that your gas displaces the blood. But for these 2 patients, luckily, with immediate prone position, they did respond very well.
And I now invite thank you, Dr. Sneha. I now invite Dr. Kalpita for her talk on multimodal imaging and management of PCV.
So good afternoon, everyone. And at the outset, I would like to thank Dr. Swati for giving me this opportunity to talk on this podium. So today I'm going to talk about PCV, obviously, but a completely different spectrum than what Sneha had shown. So I'll directly, initially I will start with the case. So this was a 48-year-old gentleman. The history starts in 2009, even when I didn't start my ophthalmology. So this patient came with a decrease of vision in the left eye. For 3 months, best corrected visual acuity in the right eye was 6.6 and 6, left eye was 6.9 and 6. That time, we used to have time domain OCT. This OCT showed subfoveal fibrovascular membrane with some presence of fluid. Angiography was done, I retrieved the data from the file. So angiography showed subfoveal membrane with late leak, and the patient was diagnosed to have a classic idiopathic CNVM. And at that point, the patient was treated with a combination PDT with injection anti-VEGF, and he was under regular follow-up. He maintained the stable vision till 2014. Vision was 6.9 and 6 in both the eyes. The OCT shows a stable subfoveal membrane with no activity like fluid or hemorrhage. So now the patient comes back again in 2017, complains of tilting of letters in the left eye for 4 days. He maintained the best corrected visual acuity of 6.9 and 6. Now we have the spectral domain OCT, where we can see the double membrane sign, some tall PEDs, and some subfoveal hyperreflective material, or that was a subretinal hemorrhage. So we asked an combined FFA ICG, and ICG shows a beautiful branching vascular network which is sitting just under the fovea. We can see some cluster of polyps at the end of this BVN, and these polyps were more prominent in the late phase of ICG. At this stage, patient received 2 injections of ranibizumab, and patient was stable. With that treatment, the SRF and subretinal hemorrhage resolved. He maintained the visual acuity till that time, till 2017, 7.5 and 6. So now we get OCT angiography in 2018. So this OCT angiography, as we know, we do a good segmentation. The branching vascular network is very well seen. He had no symptoms at this point of time. BCVA was maintained. In the in the ORCC lab, we can see the branching vascular network, and as we know, the polyps are not picked up in OCTA. So again, the history comes in 2021. Patient was asymptomatic, but in the fundus photo, we can see there were some RP alterations at the macula, but patient starts bleeding here and there around the macula, fovea. So patient was not symptomatic. The OCT at the macula showed the double layer sign, but no fluid or hemorrhage at the macula. But if we see, this OCT angiography also showed this branching vascular network, but here if we see very clearly, some flow is seen at the temporal aspect of the fovea. So that made us to get another FA ICG at this point of time. Here we can see that the BVN at the center looks quiescent, but it grows towards pretty temporally, and the late phase we can see that the cluster of polyps away from the fovea in the superiotemporal and the inferotemporal side. At that point, patient underwent, we advised, and patient underwent focal laser to those extrafoveal polyps. Patient was not symptomatic though at this point of time, but 2 weeks later, patient comes with sudden drop of vision. Best corrected visual acuity in the left eye was 624 and 36. And the OCT shows subretinal fluid. Patient was very symptomatic, and he was under regular follow-up. He actually implicated the laser for the cause for his decrease of vision. So at this point, I got a OCTA done. The OCTA, if we see very carefully, now this BVN shows an aggressive, angry-looking Medusa head type of pattern. So because he underwent laser, and this Medusa head also was covering under the fovea. So I advised the patient aflibercept. He received 3 injections of aflibercept, and with injection, he again gains back his vision to 6.9 and 6. So now I started following up the patient with OCT angiography. With clear segmentation, we can see in February onwards, this BVN tries to dry up, skeletonized, but if we see with the time passes, the temporal edge again starts gaining a new vasculature, abnormal vasculature on the temporal side. And if we see carefully, this OCTA even picked up some polyp-like lesions. So at this point, and even that was August, so the extent of this polypoidal lesions appeared increased. So at this point, and the patient started bleeding also at the temporal edge of the fovea. He was maintaining vision, so he was asymptomatic. This thing only we could pick up because patient had a regular follow-up. So at this point, we again had a FAICG done, and here we can see again this cluster of polyps at the end of the BVN. And the late phase shows there's a pretty good chunk of polyp at the end of the BVN. So at this point, I advised the patient focal laser to the polyp. Along with that, I combined the injection. So with that, patient again gained back the vision but now he had a repeated episodes of bleeding and everything. I kept the patient on aflibercept, treat and extend. So I kept on apparently injecting, and he was bleeding also. He had specks of hemorrhage. Kept on injecting every 3 months. So he was doing well. But at this point, I could not convince the patient that why he needs injection. So after 3 injections, where I can see the temporal thing, again, some abnormal vasculature starts growing. I advised the patient injection, but patient refused. Now, after 8 months down the line, patient comes with a significant decrease in vision. From 6/9, his vision drops to 1/60, and there was a subretinal hemorrhage, intraretinal fluid, and everything. And here you can see that again this branching vascular network, again it has gained this volume. And now, because we note but patient, we have the new molecule in hand, we gave the option, patient opted for faricimab. I injected the patient faricimab, and this is the last month follow, just a couple of days back. He has gained back some vision, and he is due for his second faricimab. So what I learned from this case, so PCV actually behaves differently from neovascular AMD, and these patients actually need a pretty long follow-up. This patient has a 15-year follow-up, and the disease is still active, which may not be the case in case of neovascular AMD. And we need very close monitoring of this branching vascular network and polyps. Here comes the role of ICGA and OCTA. ICGA is the gold standard for diagnosing of PCV, and whenever we need to pick up the polyps, we need to do ICG whenever it is needed. However, when we are treating the patient, this patient can be followed up on OCT angiography. And we have a spectrum of treatment. Initially, we had PDT. We had combined PDT with anti-VEGF. Now, PDT is no longer available, and we have now in our hand the newer anti-VEGF molecules. We can do focal laser to the extrafoveal polyps, but laser can cause increased exudation. So, and combination treatment in these cases may be necessary. So I need to put these points to discuss whether if there is asymptomatic extrafoveal polyp, would you treat or observe? What is the role of combination therapy? And in this case, if you want to inject, what will be the choice of anti-VEGF? And the cause of poor vision in the end for this case. Thank you.
Thank you, Dr. Kolpita. Seems like you have a very dedicated patient who follows all your advice for last 15 years. So you have already raised the questions. Panelists to answer these.
Okay, before that, I must congratulate you for this wonderful documentation of your cases. Ota shori nilo, ekta jinish just dekhanor chilo. Can we go back to your presentation?
Yes, sir.
There is one very important and interesting point which your OCT shows, which has to be kept in mind when we are seeing OCTs in BVNs. And that has been reiterated in her presentation. Can we go back a few slides before, like August? Yeah.
Here or?
This is something that has to be looked at. You see, whenever here, these are skeletonized vessels. Now, once we come over here, we can see these are not skeletonized vessels, these are abnormal active vessels. Now, look at what is happening here. This is what we call a closed loop. So, if you have closed loops in a BVN, it means that it is going to be active again. It has to be active. So, if you have closed loops like this or closed circuits where the anastomosis is closing, You have to keep that patient under very close follow-up, and you might have to inject the very moment you find that there is the slightest amount of SRF, because this is going to bleed. This is going to bleed. Now, and on the contrary, if you have something like an open loop here, it means that the disease process is quite quiescent. You can increase the follow-up a little more. Regarding your questions, combination therapy definitely is the treatment of choice. Extrafoveal polyps, I prefer to do lasers because you never know when they are going to bleed. You find an extrafoveal polyp far away somewhere, you feel that you might leave it without doing anything. Later on, it comes with a huge hemorrhage. So I'd prefer a laser, a proper focal laser to all the polyps.
No, I totally agree with Somen, and Kalpita has managed it very well. This is exactly not the right forum to discuss all detail about it. But again, yes, these are the cases we need to have a very close follow-up, number one. But most importantly is that the creating bonding between the patient and the risk associated, like 6'9" to patient has dropped down to 1/60. So this is probably once the patient again goes to that level, then they realize what mistake they have done. So this is now our responsibility to make them realize that yes, this is possible, kind of thing. So that's what this is.
All throughout after that, except that last episode, patient was asymptomatic. So I actually had a very tough time
to convince
explaining
them,
him that
yes.
he needs treatment.
Yeah.
He took treatment for few months. Then he was like, he's okay. He doesn't want treatment. So that's how it happened. He bled again.
Yeah, one more ICG probably that point of time with the 6'9" probably would have been better for convincing them that if the polyps are still active, then you could have shown them.
Every
and
visit I explained because the BVN, the quiescent BVN was sitting under the fovea, so that was not bleeding that time. So every visit I explained the patient that your disease is temporal, your disease is not at the macula, so you need treatment. If the disease is active, you need treatment. But really had a tough time to explain him. Even he got treatment, but in between definitely, like all patients, he was also reluctant to get further treatment. So that's
very
actually
good.
the only question I have that why, because if you see the last slide also, here, so the amount of bleed is not corresponding to the vision. Because previously also he bled, but do you think this bleeding explains 1/60 vision for this patient?
Scarring is reasonable, yes. Actually, patient counseling is one of the most important part in these cases. And with the 6'9" vision, you can't convince the patient for ICG or, a set of expensive injections. But it's like that.
Yeah. So maybe sir is telling that at that particular point, getting an ICG done and explaining him for that particular point could save us from this thing happening. Thank you everyone.
Our chairperson, Dr. Debashish Das sir, your comments please. Any take-home message?
No, I'd like to know why the focal laser was not done for the extrafoveal lesions.
Laser was done, sir.
It was done for the extrafoveal lesions because just day before yesterday we had a presentation with Dr. G.N. Rao.
Yeah.
And
So first
he's
time
showing a good combination of laser along with the anti-VEGF.
No, every time it was done because laser also after we do the laser, then we have to give some time to the patient to heal and everything. So every visit we cannot do laser.
No.
First time I did laser, he had an increased exudation. He came with a drop-in vision. Second time when I lasered, I combined it with anti-VEGF injection.
Correct.
I must congratulate you, Dr. Kolpita, that the patient is still following your advice. Now the quintessential award ceremony. May I request Dr. P.N. Biswas sir to please come forward and okay, all speakers please come forward.
And a special request for Dr. Rupakanti Biswas, who's come and given his inputs for the retina session despite having commitments. Please come, sir. All chairpersons and panelists, if you can come on the in front.
So before we are running short of time, before we hand it over to the agree to disagree session, we can just squeeze out 2 minutes for a group photograph and mementos. So Dr. PNB sir, please hand it over to Dr. Somen Mandal. Dr. Janaki. Devashish sir, Ashun. Dr. Kalpita. Dr. RKB sir. Devashish sir, please come forward, sir. You give it, Devjani di. Devarati, please come forward. Dr. Sneha. Dr. Surabhi. Go. And for the moderators, Dr. Divjanidhi. And definitely for the chairpersons, I would request Dr. Tulika Di to do the honors. Dr. PNB sir, one of the senior most teachers. I still remember the B3 unit. And Dr. Devashish Das sir, our honor secretary for OSWB and always a person of inspiration. Thank you so much. Now we're running late. The agree to disagree session and a group photograph. Please everyone just stand for 1 minute. The next speakers can please load their presentations and get ready.